Ladies and gentlemen, today I'll go through a quick review on rupture uterus. Now, you all know that uterine rupture is potentially a life-threatening complication, and it normally denotes a badly managed labor. In India, it still accounts for 5 to 10% of all maternal deaths, and the perinatal mortality is as high as 80 to 95%. Though its incidence was static following better obstetric care, there is a re-emergence in its incidence following increased cesarean rates. A complete rupture is one in which all the layers, including the peritoneum, has given way and the uterine contents has escaped into the peritoneal cavity, meaning the fetus and the placenta are in the peritoneal cavity. But in an incomplete rupture, the visceral peritoneum is intact, and hence the fetus and the placenta remains within the uterine cavity, but there's a large amount of bleeding, and sometimes it may present just as a broad ligament hematoma. A scarred uterus in the upper segment, like your classical section, can give way in pregnancy, and though a lower segment normally gives way in labor. A previous cesarean scar, the incidence of it giving way is about 0.1 to 1%, but it contributes to 50% of rupture uterus. Okay? A dehiscence of scar is less alarming, meaning to say that at the line of scar it has given way. The line of scar is fibrous tissue, and so the minimal amount of bleeding is there. But remember, the fetal prognosis is good here because the fetal membranes are intact. The peritoneum may have given way, the uterine layers have given way, but because the membranes are intact, you'll find that the fetus is good most of the times. And you normally recognize this when you do a cesarean and you say, "How thank God I did it," because it's a scar dehiscence. So normally the condition of the patient is also pretty stable. There can be spontaneous or iatrogenic ruptures. Spontaneous on an unscarred uterus, yes, it can happen following obstructed labor, but in the obstructed labor is very uncommon nowadays because they normally never go to see more than 24 hours in labor. But a scarred uterus, yes, a previous cesarean scar. But the iatrogenic can be due to an operative vaginal delivery. But remember, your oxytocin and prostaglandins can also cause a problem, and rarely an internal podalic version, especially when you do it in the absence of liquor. Now, the obstructed type of rupture involves the anterior lower segment transversely or obliquely, and it often extends upwards along the lateral vaginal wall, lateral uterine wall, and downwards to the cervix and vagina. The margins of this tear may be irregular, ragged, and necrosed. But why the left lateral is more commonly involved is because the dextrorotation of the uterus, and so exposing the left lateral wall to greater forces of uterine contraction. Now, rupture of a previous scar is over the lower segment scar site and extends laterally to involve the uterine artery or downwards into, unless it has involved the placenta. It is extended to one side and involved the uterine artery. But sometimes we see hematuria, that's when it has involved the bladder. Now, there is no universal clinical features in diagnosis of rupture uterus, because sometimes, as I told you, if the uterine artery is not involved, you may find there's not much of clinical symptoms at all. But always it's your gut feeling. It's not gut bleeding, but it's gut feeling. Okay, you know that something is wrong. Now, anyone can diagnose an obvious rupture when the contents are free in the peritoneal cavity. Well, we normally don't see such kind of ruptures nowadays. But I also want you all to know, in the postpartum rupture, you suspect it when the patient is not improving with standard management of PPH. So it can happen in the antenatal period, especially like a classical scar, like a silent rupture. In labor, you can have alarming symptoms, or it can be pretty quiet when it does not involve the placental site or the uterine artery. But postpartum, it's very difficult to diagnose unless you're an experienced person. Now, the first sign is a non-reassuring, especially when I'm talking about the scar rupture in a lower segment scar, okay? It's normally a non-reassuring fetal heart rate. There's a variable fetal heart rate, late decelerations, and a prolonged brady, and a maternal tachycardia. So if you ask me what are the two things that you should monitor in a patient for VBAC, I'll say the fetal pulse, and the fetal heart rate, and the maternal pulse, okay? Now, there can be vague abdominal pain, but this pain, remember, it's a continuous pain. Remember that, okay? It is not like the uterine contractions, it comes and goes. When the woman with the scar has got continuous pain and in the lower part, be careful. A suprapubic pain, often referred to as scar tenderness. This is a sign elicited, but very often we find that it gives us false information. Many times you write indication scar tenderness, but the scar is pretty good at section. Vaginal bleed, bladder tenesmus, blood-stained urine, etc. when the bladder is involved. Normally, this is the principle. Now, like an ectopic, if you ask me, I will say, soon as you diagnose ectopic, rush her to the theater. Everything you do simultaneously, the resuscitation and the laparotomy. But in a rupture, normally there is time for resuscitation. But when the bleeding is severe, both resuscitation and laparotomy should be done concurrently like a ruptured ectopic. But in certain situations, I must also tell you, if you ask me what is the ideal management of a rupture, I will say do a hysterectomy, okay, at laparotomy. But there may be compelling reasons for us not to remove the uterus, especially if it's in a primary rupture, which is a very sad situation. So the ideal choice would be to opt for an obstetric hysterectomy to save the baby. This is the first choice because most of the times there'll be intrapartum sepsis also. Do you understand? So it is not just obstetric, hemorrhagic shock. You'll later on go in for a septic shock. Now this vertical skin incision, sorry for the spelling, but remember I heard you all say something about clamping the aorta, etc. It's very difficult when you try doing that through a fan and steel, okay? So when you got a problem and an emergency, go by a vertical skin. I'm talking about the skin. The fetus which is lying free in the peritoneal cavity, as you open, it's a rupture, you remove that. Most often the baby is dead. I told you 80 to 95% perinatal mortality. But if the placental site is not involved and when the rupture is like the scar giving baby could be alive. Okay, the baby could be alive. Then you clamp and cut the cord and hand over the baby. Okay? Now, when you go to obstetric hysterectomy, the first thing that you do after the baby is, the baby is taken out, the placenta is removed, take the uterus out. Okay, that is called exteriorizing the uterus. Identify the rent, see where the rent is, have a good look at it. You may find some obvious bleeders, just put a clamp over it. Okay, then normally we apply the aortic clamp. Now this aortic clamp is very good for us, not just for your placenta accreta, spectrum and all that. Wherever you've got a bleeding or an obstetric hysterectomy required, even in gynec, you can apply the aortic clamp, okay? Now the rules, what are the rules when you do an obstetric hysterectomy? I can't tell you too many things, but use delayed absorbable sutures. See that your knots are very tight because there's always a lot of edema in pregnancy. So see that your knots are a little extra tight. Check for any bladder rent. And if in doubt, put methylene blue. And if there is a bladder rent, you finish your hysterectomy and do the bladder rent repair last. Okay. Now, sometimes what you might see is an incomplete rupture. It may be just a broad ligament hematoma. What you see is the uterus is pushed towards one side. Clinically, when you see it, there's a large broad ligament hematoma. Now, what do you do? And if you want to conserve the uterus, it is a little difficult though. Open the layers, that is at laparotomy, open the layers of the broad ligament. You scoop out the clots, identify the bleeder. Most often it's a uterine artery of that side. Be very careful when you not injure the ureters, okay? And always the bleeder is below the pelvic brim. That is the uterine artery which bleeds most of the times will be below the pelvic brim. Even if your hematoma goes as far as the splenic flexure, remember the bleeder is always below the pelvic brim. So you open out, scoop out, identify the bleeder. Okay, and then you can try conservative measures. And if required, you can even do an internal iliac artery ligation. Okay, remember that. This is now another traumatic aspect when you can do an internal iliac artery on that side and you can probably sometimes conserve that uterus. But supposing you want to conserve that uterus and the rupture is a ragged tear, it's very difficult to suture a ragged tear. They behave very badly in a subsequent pregnancy. It's not the ideal thing to do. But there may be situations like in a primary, okay, when you cannot do a obstetric hysterectomy. So you may find that then what you do, you can also do the hysterectomy, you can also do a subtotal, but make sure that it is not a colporexis, it is not that your rent is extended to the cervix, etc. Then you'll have to do a total hysterectomy, okay? But supposing it's a cesarean scar that is given by, yes, you could do a subtotal. Now, when you see a rent, the best thing to do is, what you do is you're going to suture the rent. Now, you're going to conserve the uterus. Another scenario, okay? She's a preemie. So the first thing that you do is you clean the edges, you freshen the edges. And then when you suture that, make it a very good suture line, okay? That because that scar has got to withstand another pregnancy, okay? So remember that you will have to suture and make your suture single layer, 2 layers. You can make good suture material, get lot of tissue from the adjoining areas and make it a very good scar, okay? But even then, remember, this is the advice you will tell that patient. Say, I have not done the best for you. It's not right on my part not to have done a hysterectomy. There may be post-operative sepsis, but please remember to tell her that if she wants to become pregnant, the interval is 24 months. It's 2 years before the next pregnancy. And please warn her that the subsequent rupture rate in that particular patient would be as high as 6 to 32% in that sub. That means almost 1/3 can rupture. Do you understand? So it's not the best scenario. So the next option you can do is, supposing she's a young mother and she doesn't want her uterus removed, you can sterilize the patient after suturing the rent. Okay. So therefore, an elective early section in the next pregnancy, if she becomes pregnant, it's supposing she has ruptured around 34 weeks, you'll have to do it around 32 weeks or so. Do an early elective section. Keep her with you if she's far away from your hospital. And if she has completed a family assay, the next thing that you can do is suture the rent and sterilize the patient. Thank you.